All right, good morning, everybody. It is right at 9 o'clock, so we'll go ahead and get started. Thank you for coming. Today, we're going to be doing toxicology for EMS, and hopefully by the end of this, you guys have an understanding of some of the toxidromes that we're likely to encounter, how you generally need to approach a toxicology patient, and a kind of a better understanding of the Hamilton County protocols. As always, I don't have any disclosures to report. So like I said, we're going to talk about the common toxidromes that EMS encounters with some medications, and then more generally approach to toxicology issues, since obviously there are, millions of chemicals that are out there that we could potentially respond on. We're also going to talk about poison control centers and where they fit in with EMS, and then go over the toxicology protocol. So let's talk first about some basics. So toxins are defined as any substance that can cause harm or disrupt normal biological functions. And one of the first things that they teach us when we start taking pharmacology is really the only difference between a toxin and a medication is dose. I mean, if you think about it, anything when taken to excess can be toxic. People can drink way too much water. It drops their salt level down. They become altered. Eventually, they seize and eventually die. Same thing can happen with oxygen. If we put somebody on 100% oxygen, etc., it's going to begin burning their mucous membranes and their lung tissue, etc., and cause long-term damage. Which is one of the reasons why when we have patients on ventilators, we try and turn down the amount of oxygen as low as we can to keep their pulse ox fine. So all of this is a dose response relationship, meaning that typically with most toxins, the higher the dose, the bigger the response up to a certain point. There are many routes of exposure, primarily being ingestion or taking it by mouth, inhalation, injection, and then dermal, meaning what you absorb just through your skin. So some of the common toxins that are encountered by us are, primarily household related things. So household chemicals, medications, etc. Of course, we do see recreational drugs, alcohol, cocaine, marijuana, opioids, etc. We also will occasionally run into plants and natural toxins. Nightshade, which is very beautiful, has been used as a poison by assassins for millennia. Funny thing is, there's over in London a deadly garden where literally every single plant that's within this garden is capable of killing you. So it's a very kind of morbid place, I guess, to go visit. Of course, there's industrial chemicals too. We have to worry about, all the industry that is around us and, the things that they are storing on site or making on site. And then lastly, terrorism. Unfortunately, terrorism is something that we need to keep in mind. A lot of these industrial chemicals, et cetera, are capable of causing a lot of harm when, used in terrorist events. You can make, terrorism related gases, et cetera, from common industrial chemicals. And so it is something that we do need to keep in mind. So, whenever we're responding to one of these toxicological emergencies, the first thing we've got to do is figure out, is this scene safe? Is this something where we can actually go into that scene and deal with it? Now, the vast majority of the time, what we're dealing with is one person who got into one thing. It's fairly clear what that one thing was. And so these scenes are essentially pretty safe. However, if it's an unknown, problem, we see a lot of chemicals around, it's an industrial accident, et cetera, that's when we need to be a little more cautious and make sure that we don't become part of the problem. So remember to activate hazmat, if you're getting on scene and you see things that just don't add up, and you're not entirely sure that it's safe for you to be where you're at. Another important thing to remember is to decon your patient. So if your patient is covered in powder or liquid or something like that, please make sure and decon your patient. Even just, tap water is plenty. In mass casualty situations, the old putting a low pressure hand line, on people is pretty effective at getting the gross decontamination done. So after we've gotten our scenes safe, we then need to focus on the normal things of airway, breathing, and circulation. Try and get a sample history, either from the patient themselves or from other people that are on scene, with the main emphasis being on trying to identify what substance it is that they have been exposed to. This may mean that, if you've got a bunch of pills just strewn about from an attempted suicide, that you take a picture of everything, or you bring the pills with you in a Ziploc baggie. There are applications now on your phone that can identify most pills now by artificial intelligence just by taking a picture of them. And so it can be very helpful for us at the hospital to be able to identify exactly what pills these are. That way we can, more effectively treat things. If you've got a chemical bottle or an MSDS or something like that, take a picture of it. That allows us to then look up what is in that. And toxicology folks have access to a huge reference library of all kinds of MSDS sheets and treatment plans. It's also important that we try and identify if there's a toxidrome present. So a toxidrome is a pattern of clinical symptoms associated with specific toxins. Now, granted, the vast majority of the stuff that we're going to run into does not fit into one of these toxidromes. That's just not how, chemicals work. But there are a lot of medications that we encounter every day that when they are taken to an overdose level will fit into one of these main buckets of symptoms. And the nice thing about having knowledge about the toxidromes is it can tell you kind of what the expected course is and what the treatment needs to be. And, those of you that have known me long enough know that I'm a closet hazmat geek. I went down to Anniston, Alabama when I was an EMS fellow. And if you've never had the opportunity to go down there and do any of their FEMA chem warfare stuff, it is the best training I've ever had, hands down. But they teach you all about how to decon people. Obviously, the actors are not going to be stripped down to actual naked, and so they have these T-shirts that they wear that says "I'm naked," and so you're supposed to get them undressed to the point that it says "I'm naked," and then put them through, all the rest of the decon stuff. So supposedly they now sell the T-shirt in the on base gift shop, but I've always thought that was funny. All right. Now let's get into some of these toxidromes. We're going to look at these from a case study perspective. So we're going to talk first about, kind of how our patient is presenting, et cetera, and then kind of follow them as they progress throughout healthcare. So some of the common toxidromes that we're going to run into are sympathomimetics, which cause tachycardia, hypertension, hyperthermia. These are typically things like cocaine, amphetamines. Many of the ADHD medications are actually very closely related to amphetamines. There are cholinergic syndromes, which is sludge or dumbbell, which is typically organophosphates and other pesticides. Anticholinergic syndrome, which is dry skin, urinary retention, hyperthermia, and these are typically antihistamines, and sometimes some tricyclic antidepressants will do this in doses. And then the one that we're probably the most familiar with, which is the opioids. Unfortunately, it's still endemic in our community, and so we see a lot of this. CNS depression, respiratory depression, pinpoint pupils, and of course, this is caused by, heroin, morphine, Percocet, hydrocodone, fentanyl, carfentanil, all those meds. So let's talk first about this patient. So we have a 25-year-old male who complains of chest pain, agitation, and palpitations. The report that we get prior to arrival is that this patient was found at a party, agitated, sweating, and complaining of chest pain. Friends reported that he recently used methamphetamine and cocaine. Great combination for a Friday night. So we arrive on scene. Because the patient was agitated, etc. Police have arrived on scene and made sure that it's as safe as it can be. We have an airway that's open, but it's at risk because this guy is pretty agitated. He's breathing about 30 breaths per minute. He's tachycardic to 160 beats per minute, and he's hypertensive to 170 over 100. In addition, his temperature is 102.2 Fahrenheit, and his pulse ox is 96% on room air. His neurologic status is that he is alert, but he's extremely agitated. He's pacing, kind of has a wild-eyed appearance. He's got dilated pupils. He's diaphoretic, etc. He's got rapid pressured speech. So pretty agitated. So let's think first about what this toxidrome kind of fits into. So I'll give you a second, and then we'll move to the next slide. So if you thought that this was sympathomimetic syndrome, you are right. So we kind of gave it away a little bit at the beginning by saying the guy had just recently used methamphetamine and cocaine, but this is what happens when you use these upper type drugs, is it will cause this turning on essentially of everything. So you become agitated, you become paranoid. In high enough doses, you'll begin to hallucinate and may even progress to having seizures. These patients are tachycardic, they're hypertensive. They may begin throwing arrhythmias such as AFib or even VTAC. They sometimes will complain of chest pain, especially if they've been using cocaine. Cocaine is a very potent vasoconstrictor. It's one of the reasons why we actually use it in nosebleeds, is because it numbs everything up, but it also constricts down the blood vessels so that the bleeding will hopefully stop. But it also will cause vasoconstriction of the coronary arteries. And so sometimes patients that use cocaine on a regular basis will have an ST elevation myocardial infarction. In addition, it predisposes them to future STEMIs as well, because the cocaine kind of hardens up the arteries and makes it far more likely for you to develop coronary artery disease the longer you use it. These patients also tend to hyperventilate. Again, they're tachycardic. So they may complain of dyspnea. And the reason for that is, even though they've got a normal pulse ox, their heart is beating so fast that they may be, feeling like they just can't seem to catch their breath. Oftentimes, these patients will have some degree of nausea. There may be some vomiting. My experience has been anyone that takes these, by mouth tends to get fairly nauseous, but not to the point where it becomes dangerous. Their skin is going to typically be diaphoretic. They may be flushed, hyperthermic, but rarely do these patients need, to be dunked to cool them down. They typically just need kind of passive cooling of, getting clothing off, not putting blankets on them. Every now and then we will need to do some of those chiller blankets that are like the bear huggers, but just for cold, to get people's temperature a little bit better regulated. So our treatment plan for EMS is, we need to monitor this guy's airway because of some agitation. If he does begin to have significant altered mental status, it may be that he gets to a point where he's unconscious and we need to support his airway. We only really need to administer oxygen if he's really complaining of shortness of breath or, his pulse ox is low. We should try and get IV access if the patient will tolerate it. These folks will be very tachycardic. Having some fluids on board can help somewhat with that tachycardia, but it also tends to help prevent any downstream effects such as rhabdo, where your body begins to literally digest its own muscles for energy. We talked about cooling, that sometimes these folks will need some active cooling with cold packs and IV fluids, but rarely do they need to get dunked. If they're so agitated that they need to be sedated, some benzodiazepines are going to be your best friend. They tend to work the best, and they also help prevent seizures, which again can happen with larger doses of these types of things. We need to monitor this patient for seizures, arrhythmias, so we need to have them on the cardiac monitor. We need to monitor their temperature, and then, of course, their blood pressure and pulse ox as always. So the pharmacological treatments that we can do is we talked about benzodiazepines, and this really is the first line treatment for any of the agitation that comes from this and from any seizures that may develop. Beta blockers, people often will think of as wanting to use because it will slow the heart rate down. It'll also drop the patient's blood pressure. But unfortunately, cocaine and most of these other sympathomimetics are targeting more than just the beta receptors. They're also targeting the alpha receptors. And so this will lead, if we give them a beta blocker, to unopposed alpha adrenergic stimulation, which causes a whole nother cascade of problems. These folks may need cooling, and they need rapid transport. Most of the time, these are fine to take to the nearest emergency facility. They rarely end up, needing dialysis or anything crazy like that. And so pretty much any hospital-based emergency department is going to be able to handle this. So we get this patient to the emergency department. In the ER, we put him on continuous cardiac monitoring for those arrhythmias we were worried about. We may need to further sedate this guy with some benzos. And mainly we provide supportive care, IV fluids, cooling, mental status monitoring, etc. If it gets really bad, and we do need to take better control over this guy's blood pressure, we're typically going to use something like a calcium channel blocker such as diltiazem, or we may need to use alpha blockers, if necessary, such as Klonopin. So to conclude this case, this patient stabilized with IV fluids. We did end up giving some benzodiazepines for sedation. We did a little bit of, ice packs on the groin to cool down. The key learning points are, recognizing that this is kind of the cluster of symptoms that go with sympathomimetics. Benzos are the mainstay. Avoid beta blockers and be very cautious about managing any kind of hypertension. And then cooling and seizure management really are the mainstays of supportive care. And avoid Elmo when he's had a rough night out. All right, let's talk about the next toxidrome. So we have a 35-year-old male. The chief complaint is confusion, agitation, and dry mouth. The report we get is that the family found the patient disoriented, agitating, and removing clothing due to feeling hot. The family found multiple empty bottles of diphenhydramine nearby. So our initial assessment is, no immediate hazards. There was concern over this possibly being a suicide attempt, and so police have already cleared the scene for us. Patient's airway is patent. They're tachypnic, though, with a rate of 26. They're tachycardic with a heart rate to 140. They've got warm, dry, flushed skin. Blood pressure is 140/90. Heart rate is 140 beats per minute. Respiratory rate of 26. Temperature is 101.5 degrees Fahrenheit, and pulse ox is 98%. For their neurological status, we see them altered. They're somewhat agitated, rocking back and forth on the chair in the kitchen. They've got dilated pupils, and for some reason, we decided to listen to their bowels, and so we noticed that they really did not have any bowel sounds. So I'll give you a minute to think about what toxidrome this fits. And if you guessed anticholinergic, you are right. So anticholinergic, I want you to think of the Mad Hatter, all right? The Mad Hatter, as you can see here, he was kind of goofy. Of course, everybody in Alice in Wonderland is kind of goofy. If you look, his eyes are dilated. His face is flushed and red. And so the mnemonic to remember this is red as a beet, dry as a bone, blind as a bat, hot as a hare, mad as a hatter, and full as a flask. So these folks are delirious. They hallucinate. They eventually develop seizures. They're tachycardic. They're hypertensive. They have decreased bowel sounds and an extremely dry mouth. They frequently will be asking for water, continuously. Their skin is going to be flushed, dry, and very warm. Eyes are dilated, of course. And the full as a flask is they also will develop urinary retention. We can see urinary retention, in elderly patients with just normal doses of antihistamines such as Benadryl, let alone when somebody overdoses. And so very frequently, these folks will need a Foley catheter once we get them to the emergency department. So our initial treatment is, of course, maintaining their airway. If they're hypoxic, administering oxygen. We should, again, try and get IV access if the patient will tolerate it because they're likely going to need IV fluids. They may need some degree of cooling. Again, I've never seen anybody require, a dunk because typically their temperatures are lower than, 102. But sometimes it does have to happen. So typically, again, this is, cold packs, IV fluids, et cetera, to help treat the hyperthermia. They need continuous EKG monitoring for arrhythmias. Unfortunately, most of the medications that will cause this toxidrome also will prolong someone's QTC, making it far more likely for them to go into VFib. And of course, they need to be kept in seizure precautions as that also can occur with any of these overdoses. So as we talked about, the intervention that we would need to do is benzos for agitation or seizures, but there really isn't any pre-hospital antidote for anticholinergic overdoses. Really, this is something that you just need to transport to the hospital, ideally with an intensive care unit capability. So that around here is any of the hospital-based emergency departments are capable of taking care of this. And it's mainly just supportive care. There's not a whole lot more that these folks typically need other than time. So once they arrive in the ER, they needed some benzos for agitation. We ended up putting a Foley catheter in for urinary retention, and it's routine for these patients to have 1,500 milliliters, of urine come out with that first catheterization. If the overdose happened a couple of hours prior, and then they'll continue to diurese at that point. So we need to make up for that with IV fluids. They may require continued cooling. And then there is an antidote that will help somewhat with the symptoms called physostigmine. Pretty much every hospital in the country has some supply of this, but it's pretty rare that we ever end up administering it. And it's only after talking with a toxicologist that we would give it. So to conclude the case, the symptoms resolved with treatment. The delirium subsided within about 24 hours, and the patient was able to be discharged home 48 hours later. So the key learning points are, recognize your Mad Hatter represents anticholinergic overdose. Address the hyperthermia and agitation. Continuous EKG monitoring is critical. And then, always contact medical control if, you've got further concerns. All right. Our next case is a 54-year-old female. Chief complaint is altered mental status, vomiting, and difficulty breathing. The report that we get is that the family found the patient down in the barn. So we arrive on scene. We arrive to a farm that is actively working. There are numerous people around working on the farm. It appears that we only have one patient affected. The patient we see is, having significant secretions from their nose, their eyes. They have some foamy sputum. They're breathing about 10 times per minute with audible wheezing. Their heart rate is 50. blood pressure is 90 over 50. Again, respiratory rate is 10, temperature is 98.6, and their pulse ox is 88% on room air. Their neuroassessment reveals that they're unresponsive, they have pinpoint pupils, and they have kind of this weird muscle twitching going on out in their periphery. So I'll give you a minute to think about which toxidrome this may be. And if you recognized it as cholinergic syndrome, you were right. So there are a couple of different mnemonics that you can use to remember what cholinergic syndrome looks like. Dumbbells is the most comprehensive, which stands for diarrhea, urination, meiosis, which is pinpoint pupils, bradycardia, bronchorrhea, emesis, lacrimation or tearing, lethargy, and salivation. The other one is sludge, which typically stands for salivation, lacrimation, urination, diarrhea, GI upset, so nausea, vomiting, and E, I guess, is the emesis. Yeah, E is the emesis. Clearly have not had enough caffeine yet this morning. The most common causes for these kinds of cholinergic syndromes are organophosphates and insecticides. So organophosphates are one category of insecticides, and carbamate insecticides are a different category, but they do the same thing. Frighteningly, these are very closely related to the chemical nerve agents that are used in chemical warfare, such as sarin, taboon, VX. All of these work by basically interfering with acetylcholinesterase, which is the enzyme that breaks down the acetylcholine that's being released by your nerves. And so all this acetylcholine stays on those nerves instead of being broken down and recycled like it's supposed to. That means that the nerves are essentially firing the entire time. They fire, 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 as opposed to having brief rest periods. And so as a result, again, essentially everything is turned on. So these folks will have lots of secretions, et cetera. Our initial EMS treatment plan is decontamination. This is at a farm. Farms use a whole lot of insecticides. And this patient very likely has been exposed to one. So we need to be very careful as the farm-based insecticides come fairly concentrated. And then you have to mix it and dilute it with water before you can spray it on your crops, et cetera. The difference between sarin and a lot of the other organophosphates is simply that sarin is so much more concentrated and effective than RAID, but chemically they're very, very similar molecules. So we need to be very careful about this. There are numerous case reports of farm workers who were mixing up batches of insecticides and accidentally either splashed it all over them or fell into the vat where they were exposed to a massive amount of it. We need to manage their airway. That is after we've gotten them decontaminated, probably the most important thing. They're going to require aggressive suctioning, and they may require bag valve mask ventilation or intubation. They're going to need oxygen, generally because their respiratory rate is going to be ineffective. And then the medical treatment is atropine and 2-PAM. So duodope. You see a picture of it there on the right-hand side of your screen. Atropine is the first line treatment, and it begins to counteract the muscarinic effects of the acetylcholine that is building up. And what that means is we're going to have to continue giving a ton of atropine depending on what they were exposed to and how much of it they were exposed to. It's very, very common for folks to require a ton, as in we clean out the entire hospital's supply of atropine in order to get this patient's symptoms controlled. Pralidoxime or 2-PAM is also important because it reactivates that enzyme, which the organophosphate affected. And that begins to reverse that neuromuscular blockade. It's important that this happens in a timely manner because the longer that organophosphate is interfering with that acetylcholinesterase, the more likely it is that that enzyme is going to be permanently damaged and not be able to, begin working again. The pralidoxime allows it to hopefully be stripped of that organophosphate, and it can then be used and recycled by the body and begin having effects fairly quickly. We need to watch for seizures because, again, everything has basically been turned on, including the nerves in your brain. Frequently, these patients will need benzodiazepines to help with seizure. They're rarely agitated because they are struggling so much with their other symptoms that really this is more of a seizure control thing. We need to monitor them. They're going to need, cardiac monitoring, pulse ox, end-tidal capnography is very important. That allows us to monitor their effectiveness at ventilation, which is going to be compromised in high doses of this stuff. So nerve agent treatment is a little bit different. Of course, nerve agents, now we're dealing with, acts of terrorism. It's going to be important that you protect yourself. If there are a whole lot of people that are all having the same symptoms, et cetera, and you're kind of being called and it very quickly is spinning into a mass casualty type thing, be very cautious. You probably don't want to go into that scene, without having some protection. You need to initially focus on airway and ventilation. And so, patients that are unable to rescue themselves really ought to be put in the recovery position so that all that secretion can pool outside of their mouth, et cetera. And then go around and start administering antidotes. And yeah, you may have to give these antidotes through clothing. Anymore, there really aren't many of the Mark III kits floating around. The Mark III kits, the difference between them and Duodote was it was an atropine auto-injector and a 2-PAM auto-injector as opposed to the combination auto-injector. You've got to be prepared for seizures. Many times the chem warfare medication caches will have auto-injectors of a benzodiazepine. And that is designed for you to be able to aggressively treat a lot of patients having seizures very quickly without needing to take the time to go around and start IVs. Cover the patient to prevent any further exposure, even after you've potentially deconned them. I include this link here. This is a YouTube video. I will warn you, it is disturbing to watch. We're not going to watch it today, but if you are interested in seeing what some of these chemical warfare agents do, that would be the link to go. It is from a CNN report, I think back in 2015, when Syria likely used a nerve agent on its own population during its civil war. As I said, it's disturbing. You're going to see people that are suffering, and unfortunately, some of those people may have even died. But it's important to be able to recognize it, and that's why I have this link available. So for this particular patient, we get them to the emergency department. We end up intubating them and providing respiratory support because of the exposure amount. They required continued administration of multiple doses of atropine and a couple more doses of 2-PAM. Of course, these types of patients are going to require an ICU admission since they're on a ventilator. They're requiring a lot of extra support. And so the ICU is the appropriate place to care for them. So the case conclusion is that, after the aggressive airway management, a bunch of atropine and 2-PAM, the patient was stabilized. She remained in the ICU for 5 days with gradual improvement and no lasting neurological damage. Unfortunately, when patients overdose on something like this or are exposed to a chemical warfare agent, some of them are left with permanent neurologic damage, including, brain damage. Oftentimes, though, it is a peripheral thing where, they won't be able to do the fine motor things like they used to before. The key learning points from this are early recognition of dumbbells or sludge, um, atropine, 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 atropine. 2-PAM early on is essential if you've got it available to you. And also important to decontaminate so that you don't become a victim. The last thing you want to do is have an organophosphate still on somebody's clothes, and now you're enclosed in a box going down the side of the road, because now you potentially have become a victim. There was also a case report of, I think it was someplace, down south where they have, lots of grow operations going on year round, of a patient who had fallen into one of these organophosphate insecticide mixing vats, and ingested some by mouth. And when they got to the hospital, they had gotten deconned on scene, but when they got to the hospital, they vomited a whole bunch of the organophosphate, stuff up, and exposed multiple nurses that then became victims themselves. So um, just make sure, be careful, decontaminate. All right. Our next patient is a 24-year-old male with altered mental status. The report you get is that this male patient is at a friend's house, and he was found unresponsive in the bathroom. Nobody really knows, what's going on. So we arrive on scene. Police have arrived before us, so they seem to be doing okay. Doesn't look like we need anything additional PPE wise. When we arrived there, the airway has snoring respirations. The patient's breathing about 6 times per minute. They've got a heart rate of 132, a blood pressure of 94/62, a pulse ox of 84% on room air, end tidal capnography of 60, and a temperature of 98.6. The patient's unresponsive, and they've got pinpoint pupils. So most of us are pretty well versed in recognizing this because this is opiate overdoses. We unfortunately have a lot of experience with this and are going to continue to have a lot of experience with this. Yeah, we've made some strides in treatment, et cetera, but it is still very much a problem in the entire country. We teach the lay people at home blue, which is the breathing is low, lips are cyanotic, they're unresponsive, and their eyes are pinpoint. Again, very frequently, this is going to be caused by illicit opiates or prescription medications. The gateway to a lot of the illicit opiates is prescription medication. That's how, unfortunately, most patients get started on their opiate journey. We also will see cross-contaminated drugs, though, as well, where ecstasy or methamphetamine, cocaine. I've even seen marijuana that was soaked in an opiate kind of liquid, and then smoked and caused problems. So EMS treatment plan is Narcan, Narcan, Narcan. So we decontaminate the patient by rinsing off any powder if it was there. Their airway may need manual, opening. These folks typically do not need to be intubated because we've got an antidote that works very well and very quickly. While we are waiting for the medication to take effect, though, they may need bag valve mask ventilation and, high flow oxygen. Narcan is the mainstay of treatment. It's available to be administered intranasally, intramuscularly, and IV. It comes in a variety of different concentrations. This 4 mg spray that you see here is becoming the most common kind of nasal spray that's prepackaged. And then, of course, there's always the preloaded syringes as well. One important thing to point out, though, is the reason we use Narcan is for breathing. So if we have somebody who is awake or slightly drowsy but is arousable and they have adequate respirations, they probably don't need Narcan. We can just continue to monitor them. The goal of Narcan is not to put this person into full-blown opiate withdrawal, because then we've got a whole new host of problems, including an agitated, patient. The Narcan is there to improve their respiratory rate. And so, back in the day when we didn't have things like fentanyl and carfentanil being mixed in with the heroin, we would start it at zero point 0.2 or 0.4 milligrams of Narcan. Now with fentanyl, carfentanil, and whatever fentanyl variety is out there, unfortunately, we're requiring bigger and bigger doses. A lot of us who have been, treating patients for a while with opiate overdoses kind of have gotten to a point where once you've given, 8 milligrams or so, you're not likely going to see any significant improvement if you haven't already. And so a lot of us, the practice has been, those patients, okay, we just need to get them intubated, and they'll let us know when they don't need their airway protected anymore. And then we can get them extubated again. Of course, these patients are going to need cardiac monitoring, pulse oximetry, and tidal capnography. That'll help us monitor their effectiveness of ventilation and their breathing rate. So the disposition is, we really want to try and get these patients to go to the emergency department if we can, because the emergency department is supposed to have additional resources. Many of the ERs around here can even start patients on Suboxone therapy and get them referred into, outpatient treatment. It's not great yet, and it really is dependent on who's working, what day of the week it is, how busy the emergency department is, et cetera. But, it does work getting these patients to the emergency department so that we can get them the additional help that they need. We can have a discussion about Suboxone, et cetera, can be really beneficial for these folks. We know, though, that many of these patients are going to refuse transport. That's just the reality of the situation. So if your department is participating in any of the leave behind programs, leave behind pouch is very nice. Hamilton County Public Health has this, and Sharonville will be getting this very soon, where it's a leave behind pouch that has Narcan, it has fentanyl test strips in it, it's got a prescription drug disposal bag, a bunch of resources on treatment options, et cetera. Some places are just doing leave behind Narcan, where they basically have Narcan that they can hand out. And so it's a great idea to give one of those to the patient or to, someone else on the scene so that they can use it the next time. But I always have the conversation with them of, if you're giving somebody Narcan, it's probably not a bad idea to call 911 in case they need more. So our outcome on this was, the police arrived, they administered intranasal Narcan prior to our arrival. When we got there, we began assisting ventilations. The patient slowly woke up, thought he had used cocaine. Clearly, the cocaine was mixed with some heroin, likely. So he was not expecting this. He refused EMS transport. So instead, we provided the patient with that leave behind pouch that had a bunch of various things in it. So prescription medications are such a broad category that really going through and trying to get everybody to remember, all of the medications out there and what they're going to present like is just not practical. These are where poison control can really help you, or a toxicology reference of some sort. Because of the number of medications that are out there, they're going to have variety of presentations. Each one of them is going to be a little bit different. So some of the ones that I wanted to highlight is, acetaminophen. We see this very frequently in, patients that are trying to kill themselves. It's a very painful way to die, and it is by no means immediate. Patients initially may only have some abdominal pain and some nausea and vomiting. But as time goes by, it begins killing the liver. And so these patients die of liver failure, 6 weeks or so after their, ingestion, if they don't get treated. There is great treatment now, acetadote. There used to be a medication that we used by mouth. We still do try and use it by mouth, but it is very potent and smells of sulfur. So as you can imagine, trying to get somebody who just tried to kill themselves to drink something that smells like poop is going to be very, very difficult. So we now have an IV formulation that some of the literature is showing may actually work better than the oral route used to. Aspirin, again, another one that's fairly commonly used in attempts. In bad cases, these folks will sometimes need to get dialyzed. But most of the time, if their level is high enough, all we've got to do is alkalinize the urine. And essentially all that means is that we're giving the patient a whole bunch of bicarb through the IV and monitoring their urine pH. Because as we get that pH more basic, it then is going to help get this acid out of their system. Lithium is another psychiatric medication that is still used fairly frequently. It's a very good medication, but it's got a very narrow window before it becomes toxic. And sometimes these patients need dialysis. So it's important that we transport those patients again to a facility that is hospital-based so that they can possibly get dialyzed. Beta blockers are a common one that kids will get into because kids like to explore at grandma and grandpa's house and may get into grandma and grandpa's medication, including beta blockers. Most of the time we don't need to do anything with these. But in some cases we need to provide glucagon, IV fluids. In rare cases, does a patient need a pressor, or even more rare, pacing. Calcium channel blockers are another one that kids will get into, again, because that tends to be something Americans are on for blood pressure. And the treatment for that is more calcium. That's typically that, and supportive care is all that's needed. Some of the psychiatric meds that are out there may require different meds to control symptoms. And this can be difficult. Some of these medications are known to cause this disease called neuroleptic malignant syndrome, which is basically where your brainstem, stops working the way it's supposed to. And so these patients will become very rigid. They'll become very altered and hyperthermic. The first case of this I ever saw was as a resident, and the girl's temperature had gotten up to 108 degrees after she had overdosed on Seroquel. So we were, doing everything we could to get this girl to cool down. And then I want to leave you with a little nugget of information that was taught to me by one of my faculty in residency. He was also my academic advisor. Unless it's a benzo overdose, treatment with a benzo is typically indicated. And he's not wrong. A lot of stuff, when you call poison control, they're going to say, all right, you got to look for this, 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 this. And then, of course, if they have a seizure, you're going to want to give them a benzodiazepine. So again, if they're agitated after an overdose, a benzodiazepine is probably going to be one of the treatment recommendations. So thanks to Andy Bazakis up in Saginaw, Michigan, for that nugget of truth. Some of the others that we need to worry about are, carbon monoxide. In that situation, it's going to be high flow oxygen. It used to be, back when I was a medical student, that we would do hyperbaric therapy for a lot of carbon monoxide patients. But anymore, we're really rarely doing any hyperbaric therapy, except in some cases where it's like a pregnant person with a fairly high concentration, or we've got somebody who's got significant altered mental status from it. In those situations, we may end up doing hyperbarics, but the availability of 24/7 hyperbaric chambers has really gone down as a country. Cyanide, we just recently had training on, so administer the cyanokit. Again, if you're pulling somebody out of a burning building, you need to be thinking about carbon monoxide, but you also need to be thinking about cyanide. And so if you've got somebody who, is complaining of shortness of breath or is looking short of breath, etc., it's probably a good idea to give them high flow oxygen and give them a cyano-kit. Paint and some other hydrocarbons are frequently used for huffing. Patients will frequently get, especially the metallic, spray paint cans, and they'll spray it on the inside of a baggie and then, breathe through the baggie. It causes long-term brain damage as this happens. It causes long-term lung damage as well. The most concerning thing, though, is cardiac arrhythmias. These patients, their heart becomes extremely irritable. And there have been case reports of patients going into VFib arrest, as they were basically bumping out of the ambulance, and into the hospital. Now, is it really the bumping that did it? Probably not, but that's what the case reports were focused on. Bleach and other caustics like drain cleaner and things like that, these oftentimes are going to require monitoring in a hospital, and in some cases they may require a procedure. We sometimes need to go in with a camera very shortly after they've done this so that we can take a look and see if they have any perforation, because bleach and other very basic things will burn, horrible holes through the mucous membrane. And that's something that's going to require potentially surgical repair, because obviously, having your esophagus open to your chest is not a good thing. So poison control, one of the nice things about being in Cincinnati is Cincinnati Children's is one of the national poison control centers. Everywhere in the country, you can call 1-800-222-1222, and that is going to connect you to the closest, poison control center in the country to you. Around here, we also have a direct line to Children's, which is that 513-636-5111 number. We have to use that sometimes in the more outer, areas, because sometimes depending on where you're at in a county, you may get routed to a place that is not typically where we would transfer a kid. For example, for whatever reason, Mercy Mount Orab, their internet-based phone system seems to think that it's in Toledo, and so we always are connected, if you call that 1-800 number, to the Cleveland Poison Control Center. So we have to call them directly. Poison control can help us identify, potentially what it is that we're seeing, identify some of the treatments, but they can't actually give you orders because they are not a nurse practitioner, PA, or physician. But they can guide you, to follow, a portion of your protocol. If this is an unintentional pediatric overdose, patient got into something, etc., it's okay for us to encourage them while we're on scene to call poison control and have the patient or their guardian, have their parent or their guardian discuss things with poison control. Studies have shown that up to 90% of unintentional pediatric exposures don't need immediate referral to the emergency department. Oftentimes, this is a 1 or 2 tablet kind of thing. They just need to be monitored, and as long as they're doing fine after a few hours, they're out of the woods, and so don't need to go to the emergency department and stress the parents out, stress the system out, stress the kid out, etc. When really most of the time, all we're going to do is just basically watch them, and who's going to be watching them? Primarily mom or dad or the guardian, just with the nurse outside the door. And then, the end result of pretty much any of the toxins that are out there is seizure, coma, death. So keep that in mind. Again, benzodiazepines can be your best friend when it comes to a toxin overdose. So I thought this was funny, though. I've been waiting to use this GIF for a while, and I thought, this was a pretty good way to end a talk on overdoses. All right, I think most of the Sharonville guys are currently out because they got hit with a bunch of runs. But for those of you that remain, I'm happy to answer any questions that you might have. All right. So very quickly, I do want to take you through the protocol for this. So give me just a second to um, get that on screen. Right, let's see. Zoom, share. Okay, so hopefully now you can see the toxicology protocol. So it's M411. It was written by Mel Otten, who is both an emergency medicine, EMS, and toxicology physician. He runs the poison control center here locally and is hysterical. He's a great guy, been involved in EMS for a long time. But he keeps this up to date and did a really good job several years ago of rewriting it and paring it down quite a bit. So it goes through a bunch of the stuff that we had already talked about. It also says, here, especially for kids, that, the parent or the guardian can call poison control while we're there and have poison control guide the parents to a decision on whether or not they're going to go to the hospital. In addition, it's got a lot of the specific things that we talked about as well. So when you're not sure of what to do, you can flip to the protocol. And if it's one of the common toxidromes, it's likely going to be there. And then it's got general things as well. Or you can call poison control. Poison control is going to help walk you through identifying what it is that you're seeing and what your kind of initial approach to treatment should be. So it's a very good protocol. Next year's protocol is going to have some more information on the cyanokits with an easier to use drug dosing guide for it. So that's really the only, big change that's coming for 2025. So please do me a favor. The next time you're bored out of your mind, go ahead and open up M411 and just look through it, figure out, you know, how to kind of work your way through the protocol. So that way, when you encounter it, you know what to do. All right. Well, that is the end of training. So thank you everybody for coming. Don't forget to fill out your evaluations and to make sure that your name is on your roster so that way your agency can issue you credits.